the part one. So let us start. So leukemia, first our topics is leukemia. Just I want to say one thing that is very important, that what you will read. So you have to first of all you will read out the PDF, because it is made up of all the books that is needed. After then, my suggestion is go for the FOB case book, AKP case book, both. Here also FOB case book is important and it's helpful. So already if you have if you read out, that is very good. If you are not already read out these things, then that means you have to read out the AKP case book, that is different book. And then you have to read out the new format book. New format book is very, very important, and it is actually it is new way. Previously AKP was different, and now the way of asking questions is matched up with the new. It is applied knowledge. I'm not sure that 2022 just when the time is, and then they published it. So is very important, and already I see that some questions are from directly from this book, so you should read out this book. This book is very nice. So other than there is written examination books, but this book's question is not typical for AKP. But you can take these books to enhance your knowledge. There are many other books, but it is only to gain the knowledge, not directly like the exam way. And another thing is on really good. It's not very much OD, rather than if you discuss recall, then it would be very OD. And when you discuss, then it will take a permanent impression on your mind. So it would be good. Okay. Other than this, I think there is some seniors will say about survival guide. Okay. So remember, survival guide is something, if you just read out the survival guide books, then you can see that even clinical exam things are written there. Task is written there. I mean, they write it, the task, this is questions for tasks. And then clinical also. So it is a one kinds of notes, someone notes. So previously there was not that much books. Okay, so that time survival guide was very important, but nowadays I think it is not that much important. And its reading is also very difficult because very clumsy, very narrow lines. So if you want to read, that is I mean, if anything you read, it will enhance your knowledge, so it's not bad actually. So this is the way. So I will give for each topics, I will give a PDF, so that I mean this month's PDF, so you will get an idea. I mean, very shortcut way you can read out. And then I say that you will go for the pediatric guideline, AKP case book, and if required, then FOB case book, and also the applied knowledge in pediatrics books. Then you will do the recall paper, and recall is not that much use, or sample paper also not that much use. So I'll give topic wise a recall, and also the sample paper. So you will prepare yourself within 3 to 4 days. I think if you read every day 2 hours, then it would be enough to prepare yourself with the topics, and ultimately you will be, I mean, very ready for the exam. So let us start. So first of all, we know that there is an oncology related leukemia is very important, and it's related with the three cell line will be involved here, that is anemia, leukopenia, or leukocytosis, and thrombocytopenia. So remember, some questions confused us that there is leukopenia, but it is also mentioned in applied knowledge in books and various pediatrics books that leukemia usually with the leukocytosis, but it could be leukopenia initially also. So never confused with these things. They can be presented various way. So the three cell line loss features is there along with CNS involvement. So like even seizure disorder, lymphadenopathy, bone pain also be there. So it is taken from applied knowledge in AKP books, RCPCH AKP books, and there it's mentioned that how can be presented by the leukemia. So you see that it could be leukocytosis or I mean normal count also, just you see just 13. So it would be the by that way. And there is a FOB case which is also I mean you already knows about this. If you require, then you can ask me, I can help you by giving the this FOB case discussion. So let us discuss about the questions which is asked in this area, that is the prognosis, good and bad prognosis. We get some recall paper directly from here, that which is the good prognosis or bad prognosis. So if initially there is a massive if there is a total count is used, then it is bad prognosis, especially more than 50%. And also if it is involved like meninges, so it is also bad prognosis, or massively enlarged lymph node, liver, spleen. Meningeal involvement also important for bad prognosis. But always age is, we have to remember that more than 10 years and less than 10 years. And also it is important like cytogenetics, when you get specific genetic changes, so pseudo-diploidy and translocation in this side 922 especially, it's also bad prognostic features. And then if it is T cell acute leukemia, also it is a bad prognosis. So the question which previously asked, it was very clear cut. It's not very difficult one, but there was one question which is related with the treatment that I will discuss. So treatment is mainly chemotherapy. You know that specially designed multiple drugs is there, and this medication is usually it is first managed by the tertiary hospital. So if you diagnosed acute leukemia, your task is to refer the patient. Okay. So for example, you get a patient, this patient are suspecting leukemia. So you have to send the patient with hyperhydration. That means you will give fluid which is, I mean, 3 liter per meter square, massive fluid you will give to prevent tumor lysis syndrome, that we will discuss. But you have to send the patient to the tertiary hematology center, that is they will be done bone marrow examinations and other examination they will do, and genetic cytogenetic study. So then they will give a schedule. Okay, so that means they will give a chemotherapy schedule, and then it will be managed time to time by the GP center even. So if any problem, then they first go to the GP center, but always they check the schedule as well. Okay. And it is written in the RCPCH book that clinicians who are not on their trust register must decline if asked to prescribe, check, or administer intrathecal chemotherapy. So remember that intrathecal chemotherapy is something very fatal if it is given through the vein. So immediate death could be there. It's very important. They say that intrathecal chemotherapy, if administered, then you should not, if it is asked to give intrathecal chemotherapy, then it should not be given. Clinician or who are not in their trust register, I mean those who are not involved in the management of this patient, they should not give intrathecal chemotherapy without permission. Same type of one questions asked previously in the exam. So I'm just showing you how the question is. There is a recall paper questions that I'm just showing you. Okay, so if you see, so this was a question that a trainee pediatrician comments on new post in district hospital which provides shared care service for patient with leukemia. A patient with leukemia due to go to the theater within an hour to reinsert his central line, which has split out, and it has been agreed that child's scheduled intrathecal chemotherapy should be administered under the same anesthetics. The oncology register who has agreed to provide the prescription is now unavailable. Senior nurse in the PICU of the hospital requested from you to prescribe the intrathecal drug. So now they are requesting you, but oncology register who is agreed to provide this prescription is now not available. These are 2 points here. So they schedule intrathecal chemotherapy administered under the same anesthetics. Okay. So the trainee, what is your action? I mean, this question is difficult or different. Otherwise, leukemia related, most of the questions is very easy. Already we discuss and we will discuss further. But you just check it. The trainee should be refused to prescribe even if in this unforeseen situation, the trainee should agree to prescribe knowing the prescription will be reviewed and countersigned by the oncology pharmacy. Trainee should be agreed to prescribe after discussing, consulted, another register. The trainee should be agreed. So, agreed to prescribe. One of the things, one is with the pharmacy or with consulted or another registered, or they have to give the prescription. I mean, they will give the intrathecal chemotherapy. Otherwise, agreed knowing that chemotherapy has been prescribed by approved software prescription program. So I think answer is very much clear here. Already we discussed. So what do you think about what would be the answer? Among 1, 2, 3, 4, 5. Can you please write it in your chat box? These questions will for sure will be a repeat, because these questions came first time. These types of question is first time. So is it difficult to understand? Here they just talk with the you understand that they're just talking with the patient who having some problem and they ask to give the intrathecal chemotherapy, but register is not available. So nurse requesting you. So it is the situation that need to give this chemotherapy, intrathecal chemotherapy, not other chemotherapy. So the answer should be that you will not give this chemotherapy. The reference is the pediatrics books, AKP books, where it is written. Okay, and I'm just giving you some more information that there is a chemotherapy for management disease. Some guidelines are there. Here it is mentioned that how you can give it. Okay, so this, if you just copy and paste, then you will get these things. Okay, that is you should not give. First things is you should not give. When you can give, when you discuss with the chemotherapy lead clinician or pharmacist, so who are dedicated for chemotherapy. So not all the pharmacists are oriented with the chemotherapy, or IV chemotherapy nursing team or lead cancer nurse. These 3 person, if they are, then you can discuss, and then you, without the register for the oncology department, you can give with the consultation of these 3 persons. One is nursing team, chemotherapy nursing team, or local cancer nurse, or those who are chemotherapy lead clinician or chemotherapy lead pharmacist. Okay, so it is very nicely here. It is a guideline for the administration of chemotherapy for malignant disease. Okay, their volume 2, it is discussed. So these are the things. Then we can go for our main presentation. Okay. So okay. So other than this, oh yeah, just 1 minute. Okay. Then you have to read out these things. Although it is our topics, it will be clearly discussed in our pharmacology class. Okay, so I'm not here go in details, but in the pharmacology class, our topics we will discuss. Now, hematology, some new format case is there. So let us discuss this thing. 7-year-old girl presented with 2-month history of unexplained episodes of pyrexia. 7 years. Okay. Okay. And it is 2 months fever. In that period, she has developed widespread lymphadenopathy and one nosebleed, which has stopped spontaneously. On examination, she was pale with lymphadenopathy, okay, cervical, preauricular, and inguinal region. She also had hepatosplenomegaly. Then they give the peripheral blood pictures, which shows anemia. Then leukopenia, neutrophil counts is also low, platelet count is also low. So you have to understand, or you have to know how to interpret. Okay, that blast is 20%. So blast cell is there. Usually we say more than 20% or 20%. Okay. So what is the most likely diagnosis? Already you got 7 years and there is long time fever with this problem. So what is your diagnosis? Most likely diagnosis. So is it aplastic anemia, non-Hodgkin lymphoma, acute lymphoblastic leukemia, Fanconi anemia, acute myeloid leukemia? So some leukemia is 2 types here they give along with Fanconi, aplastic, non-Hodgkin lymphoma. So what do you think? I can write it in chat box. It's not difficult things. Na? So what is the diagnosis here? Yeah. So two answer is here. Acute lymphoblastic leukemia. Yes, the right answer is here. Acute lymphoblastic leukemia. Very easy. But I mean, if you know, then it is easy. There is T cell leukemia also, but it is not compatible with these things. We will discuss how it could be, the presentation, how it could be. So the next question is, what features of this condition signify a favorable prognosis? So the same questions in the exam. Okay. Same question, favorable prognosis, but the answer could be 2 or 3, 1, 2, 3. 1, 2, 3. So it's not like only one answer. Okay. So you have to check it carefully too, they say. So from here, what do you think? Age, male sex, high white count, age less than 20 years, low white count. What is the favorable prognosis? What could be the favorable prognosis? You can write it in your chat box.
Age more than 1 year.
Yeah, right. Thank you. One we get, then
Age less than 10 year.
actually what is written prognosis, that that it is good prognosis. It is mentioned by this way that 2 to 8 years. Okay, so more than 1 years up to 8 years, less than 10 years is included here, but here the another things is there, that low white count.
Low white count.
Yes, so it would be the right answer. When they ask you to answer, same age should not be taken, then rather than low white count would be more appropriate. Yes, thank you. So now, if we think that there is speed of recovery related another things, that leukemia is prognosis is very good. It is said that in good center or a hematology where they are managed separately in that center, acute lymphoblastic leukemia prognosis is more than 90%. So center to center vary, 90, 95, 98 different things are there, but more than 90%. Prognosis is very good. Okay. So, but the pathway is difficult. It's in the blood. So, but prognosis good normally, especially if there's no prognostic features. And when they have intensive chemotherapy for first 2 months, if they are responsive with this chemotherapy after induction chemotherapy, then good. But if there is minimal residual disease is detected by some genetic analysis and other way, PCR, different ways there, then it's bad prognosis. It's also mentioned, but it's not, no questions with this. And remember, they will not give you any questions which is related to the hemato-oncologist. So I mean, it's a preliminary exam, and also GP level or hospital management, sometimes which kinds of help you have to give. In the pediatric guideline mention only this one. Now we will check another question. Yeah. So it is also new format books. 9 years old girl, lethargy and PTG. Seen in the emergency department, febrile but pale, lethargic, responsive to questions. She has PTG over her arms and legs. Investigation shows hemoglobin, you see, total count, 1,42,000. Neutrophil count is low, lymphocyte count is okay, higher range, platelets very low, film shows multiple blast cells, sodium is 138, okay, potassium, you have to say it's high, na? You have to say it's high, urea, high, creatinine, normal, calcium is low, 2.2 is normal range, so 2.01 is low, magnesium is slightly low, phosphate is normal, yeah, albumin, urate is high. So how can you describe this biochemical result? Acute kidney injury, although creatinine is normal, pseudo-hyperaldosteronism, renal tubular acidosis, syndrome of inappropriate antidiuretic secretion, tumor lysis syndrome. I think it's not very difficult. If you are in the pediatric training, then you can appreciate this. That is tumor lysis syndrome, which means tumor actually. What is happened? Like lymphoblastic leukemia. The blast cell means baby cell. WBC is baby stage. They remain arrested. They cannot proliferate, but this baby type cell is not good for health. They could not give our normal protection, and ultimately they suppress the bone marrow, and these kinds of cells are fragile, so easily break down. And what happened, they will get this problem when this tumor and also other disease, for example, lymphoma also could be this tumor lysis syndrome. That means this abnormal cell will be break down easily and some materials coming out, and it will lead to this problem, that is hyperkalemia, hyperuricemia, hyperphosphatemia, hypocalcemia, and metabolic acidosis. So it is very indistinct. You see only calcium is low, otherwise everything is high. So it is the tumor lysis syndrome. And if you go through the recall paper, you understand that some questions are related with the tumor lysis syndrome. So what you will do, I said you that hyperhydration, that is very important. Hyperhydration, if you give, then this cellular breakdown will be compensated and there would be less risk of tumor lysis syndrome. Okay, so before chemotherapy, you have to ensure hyperhydration, and it could be done by the any hospital which is not dedicated for oncology related. Okay, so other than this, you have to go for something for hyperuricemia. So you will give one drug which is known as allopurinol. And my dear, you have to know about allopurinol as well, because pharmacology related questions, something is related with allopurinol. That means it is what they do actually. So their task is to uric acid. Okay, so limit the production of uric acid. Okay, they inhibit xanthine oxidase. Now if you go through that, it is the best drug, allopurinol. There is more good drug, that name is rasburicase, and it is a recombinant type of enzyme, urate oxidase, which produce directly metabolized uric acid. So it does not limit the production of uric acid, rather than it convert uric acid to allantoin. Okay, so it less side effects. So allopurinol is good, but rasburicase is new medication. It is better than allopurinol. So you will get these questions in the pharmacology. Just in advance, we discuss these things. Okay, but hematology related papers, if you see, then there is no question related with this. So there is a problem with the raspberry case, which is if there is a glucose 6-phosphate dehydrogenase deficiency, then you will get that. This one, someone is waiting. Okay. So then you will get this one. Okay. What I am telling you that raspberry case is problem with the glucose. They can cause 6-PD deficiency. So you have to be assay these things. So this is one of the complication, tumor lysis syndrome, and also there could be superior vena cava obstruction that is presented with respiratory distress. So any child who having respiratory distress, you get child having respiratory distress, there is no rhonchi, and the child having some rash or that is palpable, sorry, not palpable, it's a blanchable rash. If you get, there is lymph pain as well, lymph node is there, then you have to think over superior vena cava syndrome. So this is the clue. If you can remember that there is some questions like this previously they asked, although we do not get this question in the AKP exam, but you should know that superior vena cava syndrome presentation is like this. Okay, so dyspnea, chest discomfort, hoarseness or cough. Okay, facial swelling could be engorged vein in the chest wall. Also, this could be a clue. There, it is discussed in the books that neutropenic enterocolitis or tiflitis. So it is also a exam questions that child is having leukemia and complaints of severe abdominal pain. Okay, and child having fever, bloody diarrhea as well. You have to think over neutropenic enterocolitis. That means you have to admit this child, give broad spectrum antibiotics, have to keep the child NPO, and surgical review is must. But among all the complication, most important complication is febrile neutropenia. So how much important I can express, how much important, because every exam questions from here, and there is a pediatric guideline where it is discussed febrile neutropenia. So you will get, there is high temperature 38 or more than 38 degrees Celsius, and neutrophil count is low, less than 500. Okay, 500 or less than 500. So any child who having diagnosed leukemia and having chemotherapy ongoing, and you get that child got fever. Okay, so the problem is already leukemia. Okay, so need not to be, let me draw that, need leukemia. So need not to be a neutrophil count. You have to know fever means you have to be you have to confirm by doing CBC. Okay, so any complaints, then you will first you have to be admit this child actually for fever, and you will send the CBC and you will check that how the CBC is, neutrophil count in which level. Actually, it's a emergency. You cannot wait for the patient how they progress. So the scenario, if shows that child having fever, runny nose, but temperature is 102, and his younger brother is also having same issue, father mother also having same problem, fever, same issue, so they want to distract you. Still child is leukemia, so under chemotherapy, already immunocompromised, and it's called febrile neutropenia. Already fever is there, you have to confirm the neutrophil count, and then investigations, you will send the necessary investigation, that is CBC, CRP, blood culture, liver function test, urea, electrolytes, everything actually, PT, fibrinogen. But if there is a catheter, you will send the culture, okay, from the lumen or protocath. But it is also said urine analysis in all children. Remember, it is also said in the pediatric guideline. And chest x-ray, they say that if child having any problem related to the lungs, then only chest x-ray, not for all children. So for everything, all the ALL patients, you have to give this investigation along with urine analysis. Now, if the child comes, that your task is to admit this child and ensure antibiotics within 1 hour. It's called door to needle time. When you see the patient, then within 1 hour, they should be start broad spectrum antibiotics. So pediatric guideline nicely explain it. If you see, then there is which investigation that we already said, and then you have to ensure the child is not in shock, so you will give 20 ml per kg fluid, along with, if required, you will repeat it. But shock management, you will give broad spectrum antibiotics, namely meropenem. Okay, but yes, I mean, if child having previously having any problem, so if you actually, these things are, if you see this child and shock is not there, so we said that shock and meropenem, okay, but there is not shock, okay, there is not shock, then the choice of antibiotic is tazocine, okay, tazobactam piperacillin. So but you will keep the cotrimoxazole there, you will not omit it, okay. Anyhow, if child other than shock, but child having not shock, okay, but child having allergy to penicillin, if the question mentioned allergy to penicillin, then can you give penicillin, that is tazocine, that is piperacillin tazobactam? No, penicillin allergy patients contraindicated, okay, tazobactam, piperacillin, okay. So in that times, what antibiotic? You will go for IV methotrexate, sorry, IV meropenem. If the child is already on methotrexate IV, then also you will go for the meropenem. You will not go in favor of what I said. You will not go in favor of piperacillin tazobactam. Okay. Then you will wait up to 48 hours, and then if it is, then you will assess the culture and then proceed. So at the 48 hours, you will reassess, and if child's having no problem, okay, so I mean, fever is not there, culture report negative, you can discharge. But fever is continuing, okay, then you have to send some more investigations, okay. That means you will give that ultrasound of the abdomen, okay. So is there any, for example, is there any infection there? So other any source is there or not, you have to search, but you will not change antibiotic without consultation. But fever is continuing at 96 hours, in that times you can add antifungal. So this is the things, it is discussed in the pediatric guideline. I'm just mentioning the most important things you have to remember. If they ask you when have to discharge, when you can discharge, I mean, child having no problem at all, child having no for example, child having no fever, So at 24 hours, so when you discharge, you can discharge actually at 48 hours. Without 48 hours, you can't discharge. And usually culture report comes at 48 hours. Another question is child is not improved and the neutrophil count is very low. Fever is there at 96 hours, then there is a role of granulocyte colony stimulating factor. You can give it mention in the pediatric guideline. Okay, it is, but they say that once daily non-leukemia patients only. Okay, so like any kinds of neutropenia, actually febrile neutropenia is not only for the leukemia, you know. There is another question related with the mucositis. So the pictures is like this, and then give you a child with leukemia. So what's your thinking? Leukemia and these things. So it is a mucositis. Okay, it's one of the complication during the chemotherapy. It could be, and if you go through the book, the Royal College book, they say that for the management of this patient, um, if you get any kinds of tumor, leukemia, and high risk patient, then you have to take help from the PTC. There are several centers in the UK. It's called Principal Treatment Center. Okay, Principal Treatment Center. When you get high risk patient, then you can send it Principal Treatment Center around the UK to cover the population. But mucositis related only. I mean, the things is mucositis. You have to give antibiotics, oral hygiene, very important, and aggressively have to be treated. Otherwise, it can be spread. Um, here, another things now we'll discuss that is also very, very important. Many questions from here, new format book. Okay. So, a 3 years old boy present to the AE with 4-day history of shortness of breath that significantly worsened over the last 24 hours. On examination, he is plethoric in the face and there are distended veins apparent in the neck. He is tachypneic and shows signs of increased work of breathing. Air entry is poor, chest X-ray shown below. So, if you see these things, what's your idea? What could be? The problem is 3 years and yeah, so shortness of breath, okay, and tachypneic. Air entry is poor. Child is plethoric in the face. So now this is the X-ray. Typically, the question is like this in the real exam, like this. The scenario is there and the X-ray is there. Okay. So acute lymphoblastic leukemia, congenital malformation, germ cell tumor, medulloblastoma, neuroblastoma, non-Hodgkin lymphoma, osteosarcoma, pneumonia, thymoma, tuberculosis. You have to select two. So what's your suggestion? Okay. Dr. Fatima said, anyone here also wants to participate, write something? So it is a mediastinal lymphadenopathy. Dr. Fatima, exactly, you said mediastinal lymphadenopathy could be, it is widening. Okay, so you see here we can get that. 1 minute. So when you get these types of things, that mediastinal widening, and that times I'm agreed with leukemia, but not agreed with tuberculosis. So tuberculosis, for first of, you should not think tuberculosis in UK exam first. I mean, when there is a not very clear-cut scenario for tuberculosis. Actually, it is in Asian region, we always if you see, if I mean, some patients like you are with the tuberculosis, it's not a great mistake. But for UK exam, you should go for the lymphoma as well, non-Hodgkin lymphoma. So leukemia and lymphoma, these two things, okay? You should suspect from the scenario. So these things comes first, and it's a superior vena cava syndrome, no? Child having, I mean, um, you see the child having, they say plethora, okay, swelling. So in that cases, leukemia and lymphoma both would be. Here, some things you should remember, that is, if any mediastinal lymphadenopathy, mediastinal widening is there, and supravena cava syndrome, then you should not open cannula on the upper limb rather than lower limb. It should be, and child should not be under GA without appropriate care. Okay, because complete airway obstruction could be. And steroid only can be given when the child is in the oncology center, because it can reduce the mediastinal mass, and symptoms will be reduced, and then diagnosis will be delayed. So these are the small information. Then if you go for the non-Hodgkin lymphoma, then that non-Hodgkin lymphoma is, it is presented different way, but the question is mainly media abdominal mass. Okay, so there could be abdominal mass and lymphadenopathy. Child will be toxic, irritable, and there could be lymphadenopathy as well. Other way of, I mean, like child is cranky and having limb pain also could be. So different presentation. We should not forget about lymphoma, but T cell leukemia and lymphoma. T cell leukemia, and usually T cell leukemia could be a diagnosis, actually differential diagnosis of lymphoma. So differentiation is not always easy clinically. It depends on the bone marrow involvement, and it is said that if the more than 25% bone marrow infiltration, the diagnosis is T cell leukemia. Okay, it's a represent a spectrum of disease. And then what you will do for this non-Hodgkin lymphoma, for example, child comes to you for limb pain and there is a mass in the abdomen. So in that cases, you have to go for ultrasound of the abdomen, okay, and also CT scan. So some imaging is like this, and also the supportive management, for example, CBC and other things, and bone marrow. So all the things you will do, but when there is any possibility to take the any specimen, then you will take it. For example, lymph node is there, then you will take the lymph node and do the biopsy. then it would be a confirmation. So always we will try to take the opportunity of tissue diagnosis. So if you just see this new format, it's 2.19. Okay, a 12 years old boy referred to the A by his GP with a diagnosis of difficult asthma and acute worsening shortness of breath. He was relatively well until about 6 weeks ago when he developed a dry cough and difficulty breathing, especially after exercise. There is a family history of atopy. The family has two cats and both parents smoke. Despite being prescribed a salbutamol inhaler 6 weeks ago, he also required 2 courses of oral prednisolone for his respiratory symptoms. This being on benefit on both occasions. He was started on Becotit inhaler. So you see that this child having problem having asthma at 12 years, shortness of breath. Okay. Having history of atopy as well, two cats and both parents are smoke, and child was prescribed salbutamol inhaler, but an oral prednisolone as well, and Bicotit inhaler, having occasional fever, child required azithromycin 2 weeks, 3 days course of azithromycin. So um, the problem is not only the asthma, having fever also. Despite antibiotic treatment, his symptoms have progressed. His mother said that his breathing at night become noisier. So breathing at night become more noisier. Okay. Um, he has been sleeping sitting up in bed for the past 5 days. He could not sleep straight. That means a febrile pulse, okay, respiratory rate, oxygen saturation is normal, chest is mildly hyperexpanded, breath sound are reduced bilaterally, there is a quiet stridor and expiratory wheeze. So there is not inspiratory, it is expiratory wheeze and biphasic stridor. So stridor usually inspiratory. When biphasic stridor, that could be something obstruction. Okay, subglottic stenosis is one of the classical example of biphasic stridor, but that means this area having obstructed. Cardiovascular examination, unremarkable, small, mobile, enterocervical lymphadenopathy. There is a oropharynx injected, spleen is there, chest X-ray shown. So the chest X-ray is, for example, like this. Okay. So new format book, you can check that their pictures is very bad. Okay, so pictures, I do not take these pictures of new format books because their pictures is not very good actually. Okay. So what is your diagnosis? And this is classical example of question. You see, they say that this child having asthma, but it is not treatable, very difficult, having spleen also, having a fever long time, and child could not sleep straight, remain awake. So what could be? Hemomediastinum, T-cell lymphoblastic lymphoma, thoracic aortic aneurysm, pulmonary embolism, bronchiectasis, hypertrophic obstructive cardiomyopathy. And this could be, I mean, the X-ray. So different X-ray you have to see in the Google. Okay, I'm just referring one pictures. Okay, so to understand that this is a long scenario, but diagnosis is easy. I think if you understand this things, if you having idea, then you will get it. Okay, so answer is lymphoma, and in lymphoma is the answer here, but sometimes they give CT scan findings as well, so you have to check it out as well. So if you see, this is the CT scan of lymphoma, mediastinal lymphoma. So if you see that here some first of all we should know about these things, that what is the normal where actually we are not radiologists and they will not questions very minutely radiological things. Remember, they will just ask questions. I mean, something like very normal. So you see that here it shows that lungs, overall lungs, here pulmonary trunk. So there is also here pulmonary vein. Okay, but they will never ask you what is pulmonary trunk here, what is the, never ask you. But if they give you these things and you know the normal things, and then you can understand that here widening. Okay, so these are the things normal and abnormal. Okay, so if required, sometimes it's required to go for tissue diagnosis, and before that to do the CT scan. So I mean, here just mediastinal widening when give, then CT scan also could be, and how is your approach and what's your diagnosis like this. Now, okay. So now we will discuss another things that is the AKP case related. Actually, AKP related hemato-oncology only 2 cases. Okay. Now we will discuss 1 case. A 4-year-old girl present with 3 weeks history of lethargy and abdominal pain. She had episodes of high temperature, was not eating, she is passing small amounts of urine, has not had her bowel open for 5 days. Examination showed her to be miserable, pale, sitting quietly on her mother's knee. She had palpable lymph nodes in the left upper and lower cervical area, obvious ecchymosis on her abdomen and limb. Her temperature is high, blood pressure 130/80, heart rate 110. Auscultation revealed normal heart sound. There was no reduced air intake on the left lung base. So what you get, first you get that there is constipation. Even there is oliguria as well. First things what we get, abdominal pain. Okay, abdominal pain and lethargy, episodic high temperature, but they didn't say to you. Yeah. So they didn't say to you that for how many days this fever, but maybe it's long fever. Episodes of high temperatures, not eating, but lethargy and abdominal pain is 3 weeks. There is oliguria, constipation, and their child is miserable, pale, sitting quietly on mother's knee. She had palpable lymph node in the left upper and lower cervical area and obvious ecchymosis on abdomen and limb. Okay, temperature is high, blood pressure is 130/85 is for sure high for this age. Auscultation revealed normal heart sound, reduced air entry on the left lung base, even some consolidation features also. The reduced air entry could be effusion or consolidation, we have to confirm. There is a mass on the right side which extended to the coastal margin to the iliac crest. And hemoglobin shows hemoglobin low, total count, platelets, sodium, potassium, urea, creatinine. Which of the following investigation is most likely to suggest a diagnosis? Urea, creatinine, okay. Many complain. But one thing is very obvious, that is there could be a mess. There is hypertension. There is a long-term fever with miserable situation. Even abdominal pain, constipation, child is pale, and also having thrombocytopenia features because of some ecchymosis. Okay, but it is count having no problem. Now, what is you want to do? I mean, most likely diagnosis. So what you want to do? Urinary catecholamine, lactate dehydrogenase, serum cancer antigen 125, alpha protein, bone marrow aspirate. What's your suggestion? It's a malignancy. It's very much confirmed by the scenario.
Urine catecholamine.
Hmm. Very right. Thank you. Should be urinary catecholamine. Thank you.
Yes,
Uh,
maybe a neuroblastoma.
we are thinking of neuroblastoma. Yes. So, following laboratory, actually, I mean, you can think bone marrow. Can you think bone marrow? Why not? I mean, um, why not bone marrow? So, if you see that the leukemia, can it be bone marrow actually? Why not? You see ever that leukemia with hypertension?
Leukemia
How
could not be present with hypertension.
leukemia having more possibility of hypotension or shock? So
Yes.
leukemia is not presented with hypertension anytime because there is no, I mean, there is no pathogenesis. How the hypertension would be? But neuroblastoma, yeah, it is. I think it would be the difference. And also, if you see the total count, also can exclude, and it could be excluding point. But otherwise, clinically, this is very important. Actually, if they didn't give you, then it could be there would be some fallacy. So when there is a hypertension and the clinical features is malignancy indicating, then you should think two. That is neuroblastoma. Another is Wilms tumor. So these two things. So when you think over neuroblastoma, then urinary catecholamine will become first, because it's a tumor of sympathetic origin. So they by this way the hypertension is. And of course you have to do the ultrasound because the child having, because one of the recall question is scenario is like this, and they ask you two investigations. Among them, one was ultrasound and another is urinary catecholamine. So ultrasound, at least they can say how the mass is, and it is, I mean, which origin, liver or other, so another separate mass and how it is. But yes, you have to go further. I mean, you have to do the CT scan and other things, urinary catecholamine, and all of the investigation actually you have to do. So that is even MIBG scan, and you have to take the things of so if it is possible, then you can take the biopsy from the mass. So but catecholamine is here, which is produce hypertension actually. One of the pictorial diagnosis is like this. So it's called raccoon eye. So you see that looks like bruise marks around the eyes. So one of the differential diagnosis is non-accidental injury. But non-accidental injury, even it is usually unilateral, not bilateral, and other symptom can help you to differentiate. Other than raccoon eye, even there could be other differential diagnosis. So ophthalmological, but when you get the child is open their eye, then you will not think of orbital cellulitis, and there's no problem visible, any problem with the eyes, only there is a bruise marks around the eyes. It's one of the characteristics of neuroblastoma. Yeah. and also head trauma, one of the differential diagnosis. So neuroblastoma questions when there, then you will must get the CT scan. Okay, so the CT scan, I mean, this CT scan is very well known exam question. So if you see that this CT scan shows that there is a mass, so origin is the on the side of the kidney, and there is another kidneys here, and there is a calcification in between. Okay, the margin is not sharp. Okay, so but there is ultra is there. It's not displaced, but here some liver having some also hypodense shadow. So there could be some metastasis or not. We have to further confirm by seeing the other pictures. CT scan, other CT scan. There are many slides, na, according to this. So, we will see another things. Are you tired? Or should I stop here, or we just continue? I think oncology we should complete, na? Then we can take the hematology next day also. But just want to complete it. So another scenario, no, there is more things remaining. Which of the following laboratory users suggest the metastatic disease? Select one answer. Bone marrow aspirates, C125, clotting studies, serum lactic dehydrogenase, urinary catecholamine. Okay. Hmm. So how can you understand that it's not metastatized? Or how can you understand it is metastatized? Actually? Any answer for this? What's your thinking? Yes, thank you. Thank you, Dr. Fatima. So, bone
Bone
marrow.
marrow.
Yeah. Dr. Sitara, you want to say bone marrow or any other things?
Bone marrow aspiration means
Yes, bone marrow.
metastasis to the bone.
Yes, so it's the most important. But yes, we will not forget to do the LDH clotting. It is we usually practice to do this, but related to the question, we have to say the bone marrow. Um, okay. Then the next scenario is 2 years old girl Ili attend her GP surgery with her mother. She has one episode of hematuria, but otherwise well. There is no other history note. Examination reveals a firm mass in the right side of the abdomen. Blood pressure is 145/85. So again, it is raised. There is a hematuria proved by the urine analysis. So what is your diagnosis? Hematuria and hypertension at 2 years old. Child have no other problem. Child is not very much cranky or irritable. Nothing is written here. So B cell lymphoma, hepatoblastoma, nephroblastoma, neuroblastoma, MCDK, rhabdomyosarcoma. All are the tumor except MCDK. Yeah. I want to just check it. Okay. Yeah. So it is nephroblastoma, very classical pictures. I mean, whatever the question, they are giving these two things. I mean, the diagnosis could not be different, and you will not forget if you just read it one times. So it's so obvious, but sometimes they give it like this, some other fallacy they give. So for example, if I said that this child having mm, they have large tongue, so what could be your diagnosis? Just one thing.
Can you repeat me?
So this child also having um, large tongue. Okay, I'm saying that having some problem in the at the age of uh, 13 days, child having a surgery in the abdomen as well.
Beckett-Lehmann syndrome?
Yeah, Beckwith-Wiedemann syndrome. So that is macroglossia, umbilical defects could be in the Beckwith-Wiedemann syndrome, and also there could be horizontal crease in the ear. So sometimes questions is like this, Wilms tumor, but they just give you some other scenario to know the other diagnosis. And there could be um, other diagnosis. So related to this, that is, if they give you like with these things, there is microcephalic trochidism or umbilical undescended testes or any reader is there, then another diagnosis that you have to remember, that is Weger Wilms tumor, any reader, genitourinary abnormalities, and mental retardation or growth retardation, Weger syndrome. So it is another things, but I think there is no questions with Weger, but it's very well known Beckwith-Wiedemann. Now, if you just see this CT scan of the abdomen, so what you get it here? So there is a mass arising from the kidney. Outline is very regular, and there is their their contrast having changed here. With the contrast, one specific sign arises. Okay. So here you get that it is called claw sign, and it is nephroblastoma. I don't think there is much distortion, and there is no calcification that was previously in the other scenario. The neuroblastoma. Here there is some calcification. Okay, and their margin was not regular in neuroblastoma, but otherwise looking same. And the claw sign is here specific for nephroblastoma. But otherwise, no, in the bowel, we do not get any, metastasis. Okay. There is another pictures, I hope to see. And here bowel is displaced even. Okay. So this is the things actually. If they give you some scenario and this CT scan, that times it would be easy. You can get it from the scenario, but if they don't give you any other information, then it's not easy. So you see neuroblastoma, and now you see nephroblastoma. Okay. Sometimes it is confusing. Not, it's not the only pictures. Different pictures. So I repeat, it is confusing. So you have to check it. So well circumscribed. So it is different. Nah? Well circumscribed nephroblastoma clause. I will say it. Classification uncommon. Displaced is there. Renal vessels are displaced. But neuroblastoma calcification we get. So it's easy. Now hepatoblastoma related only one question in the previous recall paper. So it's like hepatoblastoma can present only with the mass, and by the investigation we can see that there is liver involvement and other features of malignancy like anorexia, lethargy. These things are there. So normally what we get, AFP is very high, could be related with family history of polyp, also could be with the backpeak pediment. So for these patients, we have to go for the tissue diagnosis, that means histopathology, but ultrasound and CT scan must, and here you get a tumor. Okay, so you see it is not in the kidney side. See, this is the things. And after chemotherapy like this, okay, then maybe surgery was done, and I have to check it what is written for this successful tumor with left lobectomy. Okay, so lobectomy was done. But yes, they will not give too much pictures, just one pictures if they give. But I think so far they just give nephroblastoma and neuroblastoma CT scan. So so tumor related something more is there. I think we can proceed now. You'll become tired. I don't know. So 9 years old girl with von Willebrand disease present with a 3-month history of uh, right-sided knee pain. There is no history of trauma, and the X-ray is like this. Okay, knee pain, and there is no history of trauma. New format case. Okay, and there was no swelling. Normal examination, knee, ankle. Hip external rotation was limited by pain, but otherwise normal. Extra examination of the hips reveals a transverse fracture of the femoral shaft just below the left level of the laser trochanter. So if you see, then there is a fracture. Where? Here is fracture. What is this? Also fracture. And here shows like a circumscribed lesion. No? Circumscribed lesion. It's bony cyst, simple bony cyst. Looks like this. You can say that well demarcated lesion, loosened lesion. Okay. So with these pictures and fracture is there. So what's your diagnosis? You can say two. Osteogenesis imperfecta, primary bone tumor, juvenile rheumatoid arthritis, fibrous dysplasia, slipped upper femoral hypophysis. So I think you can exclude slip upper femoral epiphysis by only the knee X-ray. We cannot. We need to know the here hip X-ray. It's not plain X-ray also. So osteogenesis imperfecta could have multiple fracture, but here is bony lesion, and then there is fracture. So GIA having not any possibility with these things. So very easy to say that two diagnoses here: bony tumor, fibrous dysplasia. Okay. So fibrous dysplasia also could having same X-ray. We will check fibrous dysplasia. How? Polycystic fibrous dysplasia. It is endocrine chapter. Okay, McCune-Elbert syndrome having these types of changes. So it looks like fibrous is replaced, fibrous tissue. So these two is our answer. And what is your investigation when you know that these two diagnoses? Can you please say for this bony tumor and fibrous dysplasia? Okay, so actually here any things I mean fibrous dysplasia related investigations here is not. So here our diagnosis is alpha we bony tumor, so alpha fetoprotein, carcinoma, embryonic antigen, human chronic gonadotrophin could be. Already we have X-ray and chest X-ray. We can see that to know that is there any, I mean, it's already spread or not. Okay, so these two investigations further could be there. So I think this case is also important for the exam. We should be serious about these things. Ewing sarcoma, osteosarcoma, both is the possibility. Okay, remember. So there are some questions with the Ewing sarcoma and osteosarcoma. Their presentation is like sometimes fracture, sometimes that means it is diagnosis is by doing the X-ray you can get it, or sometimes having knee pain and systemic features. But to differentiate between the osteosarcoma and Ewing sarcoma, it is written in the books that it is difficult to differentiate. But Ewing sarcoma could have systemic features more like fever. Okay, and the site also like Ewing sarcoma um, could have diaphysis more. Okay, but osteosarcoma is near about the knee joint. Okay, and it is said that 90% in the metaphysis, growth plate of the bone, and 80% around the knee. So this is the site of osteosarcoma. So these are just could be by this way differentiate. And another is X-ray. Oh yeah, Ewing sarcoma is also having root pain, also nerve root pain could be. So if you just check it, then sunburst appearance goes in more favor of Ewing sarcoma. There is a triangle, you see, Codman's triangle. Then it is actually possible in both osteosarcoma and Ewing sarcoma. Moth-eaten appearance. So this is more in Ewing sarcoma. This is the things actually it said. So you have to just know about these things. So this is the difference. It is written the difference between these things because at least two questions with the two difference. Now If you go through a fall during physical education lesson at school, a 7 years old boy attends to the emergency department following a fall at school when he tripped over and hurt the side of his head. His teacher reports that he has been increasingly unsteady on his feet during physical examination lesson over the last few weeks. School was concerned that he had lost interest in the lesson. His writing had deteriorated. His mother reported that he had vomited, complaints of headache several times on examination, blood pressure 94/50, truncal ataxia, pus pointing. There is no evidence of papilledema on fundoscopy. So what is the most likely cause of his ataxia? It's another question, okay? So child is unsteady, that means ataxic gait, okay? Blood pressure is normal, there is truncal ataxia, everything is cerebellar ataxia related. There is a papilledema on fundoscopy. So there is increased intracranial pressure. Then is it ataxia telangiectasia? If it is ataxia telangiectasia, then the child will be lean, thin, failure to thrive. There would be some telangiectasia in the eyes, ears, neck. Okay, basilar migraine would be long history, and there is a remission and relapse. Cerebral abscess. It's not cerebral, nah? It is not like any upper motor sign. They say it. Idiopathic intracranial hypertension could be papilledema, but there is no headache here, and cerebellar sign not in favor of idiopathic intracranial hypertension. Long QT syndrome is something like they would having uh, some other problem like chest pain, sudden fall during education, during playing. So they said that a fall at school when tripped over an hard side of his head. It's not like child is doing exercise and fall. It's not like this. In that cases, we will think of a long QT. Opsoclonus myoclonus ataxia syndrome. It is one of the features of neuroblastoma, opsoclonus myoclonus ataxia. So there would be some other features of neuroblastoma, and they would having abnormal eye movement, opsoclonus myoclonus, along with ataxia. Post varicella infection. They said anything about post varicella? Like there is varicella, some lesion over the skin, followed by this happened? No, this didn't say to you. So posterior fossa tumor, it is one of the differential diagnosis of acute ataxia. A child having acute ataxia actually. Subdural hematoma of the head trauma, okay. So now if you see that the CT scan report, then you can understand that it is a cerebellar tumor. So it could be with or without CT scan report. This shows that there is a medullary tumor is there, medulloblastoma. There's a high possibility of medulloblastoma. But did you understand my point, what I said? If you have any problem, you can ask me. If you don't understand the explanation, what I said or not.
Yes, ma'am, understood.
Okay, thank you. Now, what I should say, oh yeah. So if you see, following investigation is the most useful at this stage. Select one answer only. 24 hours blood pressure profile, ECG, EEG, lumbar puncture, MRI of the head and spine. So when you get already, I mean, it is not CT scan. Remember, it's not CT scan, especially CT scan not obviously give information about the posterior part. So MRI, if CT scan also a
MRI scan,
option,
head and
MRI,
spine.
even the pictures showing the MRI, okay, that is the medulloblastoma. So when there is a brain tumor, they can present it to us different way. It's not like always typical presentation. Even we know in the endocrine chapter, it will be greatly discussed that they could have precocious puberty, delayed puberty, even they could be presented with DI, diabetes insipidus, okay, growth would be delayed. So different presentation depends on where the brain tumor is. So when hypothalamus, then different presentation. But when the cerebellar, then this presentation, cerebellar involvement will be there. Even sometimes they could be associated with some other things like neurofibromatosis. So type 1 glioma, they could have optic problem with some brain tumor. Okay. Type 2 is mainly acoustic neuroma, so auditory involvement. Tuberous sclerosis could have also brain tumor, and you know the tuberous sclerosis having hypopigmented lesion over the skin, and many more things. It is not our topics today. And then you should know about prepubertal testicular teratoma. Some information, not very much used, because at least 3 times, 4 times this question came. So there is they have to say that there is a swelling in the tumor, and it is consistency is hard. Okay. And this NHS site prepubertal testicular testoma is discussed. It is said that usually they do not have any systemic features. Even if it is like previously having testicular is not appropriately placed, so surgery is not done. Surgery is not done. That's undescended testis. Then higher risk of malignant change. So it is another clue. Physical examination could be totally normal, but we can get this tumor, and not always undescended testis. It we have to, I mean, remember, and we have to check for any lymphadenopathy is there or not. There is one question with methotrexate related, although I mean, this question is methotrexate, not always with the hematology, but remember that methotrexate is sometimes they used for GIA or leukemia related or any tumor related. So methotrexate, if they used, and that times they develop fever, that what is your task, what you should do. You have to, it is a immunocompromised drug, so you have to stop the medication and stop and admit this child, start antibiotics. Okay, so you can read out, and there is another questions related to the rhabdomyolysis. Okay, so rhabdomyolysis, the things is like trauma, and the trauma is having muscle injury, severe trauma, followed by they could have red urine, they could have chest pain, and in that times rhabdomyolysis should be in your mind, and you will give the patient, you have to check the vitals, along with you will check the CK, it could be high, there could be hyperkalemia, there could be serum creatinine will be high, so kidney injury is there. Ultimately you have to give fluid resuscitation is made, and if required, then you have to go for hemodialysis according to the presentation. But these questions came several times, they love to give it. Okay, so I think we completed the oncology part, as it is the first time, so I don't want to go in I mean, just I want to stop here. And then again in this week, probably in the Wednesday, we will again do the hematology related things. So some questions are very important in the hematology. We have to read, but the things are like this, guestbook and other things. So thank you for your presence and help. Um, so if any query on anything, you just directly message me. I'm happy to answer both. Thank you. Do you have any questions that we can discuss related to the oncology or anything more? No problem. Thank you. So
Thank
good
you,
night.
ma'am.
Yeah. Thank you, Dr. Sitara. Okay. See you soon. Inshallah. Everyone. Assalamu alaikum. Good night.
Good night.